Good morning, everyone. Thank you for all the faculty and trainees and consultants joined us all over the world. Today, in this 10th module of the iTrue seminar, webinar type of sessions, we are going to discuss the surgical treatment options for benign prostatic hyperplasia. No one can believe that in the past 10 years, the amount of work done in BPH with the array of newer energy sources available, which is unimaginable. We have so many very good energy sources available now. In fact, we really struggle to fit all the energy sources into this webinar program. I will share my screen and let's start the proceedings. So Mahatma Gandhi said the future depends on what you do today. But I think what we are doing today is actually the future. And some of the energy sources may not be available in various countries, and some of the countries may be in a very early learning curve. I hope this meeting will break the ice and will help to introduce the energy sources to the trainings and also to the consultants. This is the 10th module. My thanks to the Triumvirate, Bhaskar, Bhavan and Zishan, the three brains behind this webinar module series. And I'm very thankful to my faculty. They are all from different parts of the world, and it's so nice to have so much expertise in one platform. We have a very tight packed schedule. We will try to finish this maximum within 2 hours. I'm sure every talk will be a wonderful one, which will be quite enlightening. The viewers will get some MCQs popping up, so please keep answering. And in the end, we will discuss the MCQ answers and go for some interesting case scenarios. I'm quite happy to introduce and welcome our first speaker, Hashim Hashim. He is the Professor of Urology and Director of Urodynamics in the world-renowned Bristol Urology Institute. Yes, Hashim, the floor is yours.
Thank you, Ananda, and thank you for the invite and the kind introduction. And it's really a pleasure to be here. And it would be nice if we can see each other and meet each other in person, but this is the world we live in at the moment with COVID, and it seems that we are having more meetings now, which is good, but it would be nice to have it more in person rather than in virtual. I've actually just in the middle of doing a urodynamics course with Spain, where we're giving lectures as well. So I will start with this. So I'll be talking to you about the evaluation of male LUTS. I hope you can all see my screen.
Yes, Hashim.
Excellent. So I think the first thing to talk about when we're talking about male LUTS is to talk about the classification of male LUTS. And this is divided into storage, voiding, and post-micturition symptoms, where the storage are mainly the urgency, the frequency, the nocturia. The voiding is the slow stream, hesitancy, and so on, and then post-micturition. But it's also important when evaluating men with lower urinary tract symptoms, we don't forget the function of the erectile tissue, and that has to be inquired and assessed as well. So I'm also going to start off with talking about how the terminology changed really over time. And you can see that the EAU guidelines started off with benign prostatic hyperplasia, but over time, this has actually gone, and we now call it male lower urinary tract symptoms, including benign prostatic obstruction in the non-neurogenic patient. And in 2021, this hasn't really changed. It's still male LUTS, including BPO. And that is important because BPH really is a histological diagnosis. And unless everyone has a biopsy of the prostate, we should really be calling it BPE, which is benign prostatic enlargement. And if it's causing obstruction, then it's called benign prostatic obstruction. And it's a general term for the prostate causing obstruction. But if you have outlet obstruction, for example, for strictures, then it's called bladder outlet obstruction. And this is now the accepted terminology both in the AUA guidelines and in the European guidelines. So what causes male LUTS? Well, the reason we moved away from prostate and prostatism is because patients don't complain of that. They complain of lower urinary tract symptoms. They could be related to the bladder, they could be related to the prostate, and could be related to many other things that can cause symptoms in the bladder, which we talked about at the beginning. So what do we need to do to assess these patients? Well, medical history is important. If you don't speak to patients, then you won't be able to assess them. So this is based on clinical principles. Symptom questionnaires as well are important to be used in assessing these patients. And the commonest symptom questionnaire used is the IPSS. However, again, this is more looking at prostate rather than assessing things like incontinence and post-micturition symptoms. So the recommended one is the International Consultation on Incontinence Questionnaire for Male Lower Urinary Tract Symptoms, which looks at incontinence and symptom bother for each of these symptoms. There's also the Danish Prostate Symptom Score, which has a symptom bother on the individual items, but is mainly used in Denmark. So why are we saying the ICIQ MLUTS? Well, this is a publication comparing the ICIQ with the IPSS, and basically the conclusion was that the ICIQ measures all lower urinary tract symptoms, which is what we are assessing. So even when you operate on the prostate, patients will suffer and have other symptoms and not just voiding symptoms. And therefore, it's important to assess the whole lower urinary tract. When assessing these patients, a bladder diary for 3 days, a validated one, is needed, and that is based on strong recommendation from the European guidelines. And the ICIQ, again, is the only validated bladder diary in the world. This is a 3-day bladder diary where patients record their amount of fluid they drink, the type of fluid, how much they void, and bladder sensation. Rectal examination, again, that is recommended in the guidelines. So feeling the prostate does help you assess the size of the prostate and also the texture of the prostate. And what I tend to do usually when assessing the prostate is, you know the width of your finger, you know the length of your index finger, and therefore you can briefly assess the size of the prostate based on the area that you feel. Urinalysis, again, is a cheap, easy way to assess problems. Looking at different parameters on the dipstick, again, is recommended by the guidelines. Prostate-specific antigen, this is probably more related to wherever you are in the world and healthcare system. But in general, most guidelines around the world recommend doing a PSA test to look at, well, you can use it for progression of disease in terms of benign prostate, but also to assess for cancer. But patients need to be counseled about having the test. Renal function test, in general, there's not much evidence about doing renal function tests. Blood tests basically, but the recommendation from the European Association is that there is a strong recommendation, especially in those who have other comorbidities such as diabetes. Post-void residual, I don't agree with this recommendation. They say that there's a weak recommendation to measure post-void residual. However, later we'll talk about the American guidelines, which recommend doing a post-void residual, and actually it's part of doing a flow test. So I would say that a flow test and a post-void residual are important in assessing male lower urinary tract symptoms, to look at the voiding pattern of the patient. So if we look at this patient who came to have a flow test, the important parameters include a maximum flow rate, the voided volume, the residual, but also the shape of the curve. And this shape of curve is suggestive rather than diagnostic of benign prostatic obstruction. You can see here that it's going up and then coming down with a very long tail. And this is usually suggestive of bladder outlet obstruction, but not diagnostic. So the only way to diagnose bladder outlet obstruction is to do invasive urodynamics. And again, the guidelines published in 2021 have not been really updated because it says that there are no RCTs, randomized control trials, to look at bladder outlet obstruction or the use of urodynamics in bladder outlet obstruction, which is not true because this publication came out last year, at the end of last year, looking at the upstream trial, which was led from Bristol, comparing the use of urodynamics in men with lower urinary tract symptoms. And the conclusion from that is that there is a role, but it has to be, we have to find what that role is in terms of diagnosis bladder outlet obstruction in men. This criteria would have to be modified and assessed in the future. What is not recommended is ultrasound scan of the upper tract. And again, if patients don't have a residual, then and they have normal blood tests, renal blood tests, then there is no need to assess the upper tracts in men. And that is why the recommendation is you don't need to do upper tract imaging. The same thing with imaging of the prostate. You only need to do imaging of the prostate if you are considering surgical treatment, because they'll give you much better assessment on size of the prostate when you're considering the different surgical options, which you will hear about later on throughout the next 2 hours. Similarly, voiding cystourethrogram is not indicated, and if you're doing video urodynamics, then you would get a cystogram anyway. But in general, you don't need to do a cystogram as a baseline investigation. And similarly with cystoscopy, if the flow test looks normal in terms of shape and also pattern and flow, then you don't need to do cystoscopy. But obviously, if there are red flag symptoms such as hematuria or suggestive of a urethral stricture or bladder cancer, then you may want to consider cystoscopy. Again, the recommendation is not to do it in standard index patients with lower urinary tract symptoms. And similarly, for other non-invasive tests, they should not be offered as alternatives to pressure flow studies if you want to do urodynamics and confirm bladder outlet obstruction. So in terms of algorithms, as you can see, the main basic investigations that need to be done for men with LUTS is a history and examination, a symptom score, a physical examination, and urinalysis. PSA can be done, and measurement of post-void residual. If the symptoms are not bothersome, then you don't need to do anything. If they are bothersome, then you would go on to further assessment with a bladder diary, an ultrasound assessment of the size of the prostate, and uroflowmetry. If they have a significant post-void residual, then you may want to consider an ultrasound scan of the renal tract. Treatment is then planned accordingly, and medical treatment can be initiated. If you want to go ahead with surgical treatment, then you may want to consider pressure flow studies. If they have abnormal rectal examination or suspicion of any other red flag symptoms, then you would need to treat or assess according to standard guidelines. So you can almost have a one-stop male LUTS clinic where you would assess all the do all the baseline investigations and start medical and then potentially surgical therapy for men with lower urinary tract symptoms. So in conclusion, I did say that I'll also mention the American Association guidelines, and these have been updated recently, but you can see here that the American guidelines agree with the European guidelines and most of the other international guidelines, where patients have to start with a history examination and a symptom score and a urinalysis based on clinical principles. Assessing the size of the prostate, again, is important, and measurement of post-void residual and flowmetry is important. So all these are based on clinical principles. Pressure flow studies should be done prior to surgical intervention if they may change the diagnosis or the management based on expert opinion, and basically also that clinicians should inform patients of the possibility of treatment failure and the additional need of further surgery. And what is now being discussed further are patient decision aids for patients coming in for surgical options following assessment and treatment. So I hope this is a quick summary. It's always difficult in 10 minutes to go into detail with these baseline investigations, but I hope that it gives you an idea about how to assess these patients with male lower urinary tract symptoms. Thank you very much for your attention.
Thank you, Hashim. That's a very comprehensive talk, and that forms a kind of a strong platform for our rest of the session. Thank you very much. Next speaker we have is Petros. He's from Cyprus, and he's going to start with one of the very minimally invasive surgical options available. We are going to start from the missed to the mega surgeries. Yes, Petros.
Thank you, Ananda. Actually, it's a very good timing to follow on Hashim's presentation on how to evaluate the patients. Let me just, sorry if I can. I will have a very brief presentation on the Eurolift, which is the minimal invasive treatment for BPE, as we put it. We will try to put some of the details mentioned in Hashim's presentation, which is a must for every clinic into practice. These are my disclosures. So the Eurolift is, well, the way, if we can use a metaphor, is nothing more than a glorified stapler. But it takes some skills to be able to implant the, to insert the implants in the right places in the prostate, securing an anteromedial channel, because you don't get a second chance. Most of the other modalities, you can go back and amend any sort of mistakes. So with the Eurolift, given that it's very minimally invasive and you basically, it's a day case without the use of catheter, the people can be ambulatory and go home the same day. It requires some skills. This is the device. It comes with the scope of its own, 19 to 20 French. This is the gun, as I call it, and it has a handle. The blue handle is the one that releases, deploys the capsular tab made of nitinol, which is a combination of titanium and nickel. Then there's a polyethylene absorbable stitch that will be revealed as following the blue trigger, you press the gray, and then by the simultaneous move medially and proximally towards the bladder neck. You start seeing the capsular tab, which is made of stainless steel. And that's when, by using the little handle here at the back, you cut the stitch over there and you release it free in the prostatic urethra. The angle, this is the device. It comes, it's provided, the scopes are provided by the manufacturer. And at the moment, the way things are, you're using a single gun for a single implant. On average, mentioning the guidelines, you use about 4 for an average size prostate. In our series, we use 3 for some reason. So this is the implant compared to a human hand, just to give you an idea of how small it is, regardless of how gigantic it looks in the cystoscope. And that's the actual procedure with the lithotomy position placed with the patient. As we mentioned before, by pressing the blue trigger, it releases the capsular tab, the medial base. You have to use an angle of about 15 to 20, well, maybe 20 to 25 degrees. And you have to place the capsular tab, which is the most important one, in a specific angle. So it has a shape memory capability. So it adapts and finds its place to the capsule. The rest is followed by the stitch. As you press the gray trigger after the blue, releases the stitch. And then by using your thumb, it releases the implant altogether in the urethra free. Now, we can have different surgical techniques on how to use it. Being ambidextrous is recommended, but we're not going to hold it against you if you're just using one hand for either side. Again, very briefly, these are the steps. As you're going in the urethra, you assess with a scope, and then you place, starting from the proximal side, you place one on each side. It's not used like the resume, for example, but you have to deal with one lobe first and then move to the other. You work on either side first and start working proximal to distal. Of course, as your experience gets bigger and your confidence gets higher, then you can use techniques of your own, you can improvise, but to start with, and when offering procedures on general anesthetic, this is what is recommended, proximal to distal. This is a cystoscopic photograph of very familiar, we are very familiar, all of us, with it. A view of the prostatic segment from the verumontanum before the treatment with Eurolift, and this is after. As you can see, a successful treatment is considered when at the end of it, you can see the bladder neck being open, and hopefully that will secure a good free flow. The small indentations that you can see on the other side, or either side of the lobe, is obviously the stitches pulling it back. This is not a very big prostate. It looked like 2 of them did the job in this case. The guidelines, they certainly recommend the Eurolift as an alternative treatment now. They are being updated constantly. They are being, even the Eurolift device treatment is considered as a first option, as a primary treatment, even before medication coming from NICE. It's something that certainly younger people who want to preserve sexual function, like the ones we see, for example, with me having a special interest in andrology, is certainly a very important weapon in our quiver. The EAU guidelines, they recommend the treatment following, of course, the tests that is mentioned in the clinic, which is can be a very well one-stop clinic, as we have instituted in 5. They've been more conservative to start with, so they recommend no bigger than 70 mils size prostate. And as we mentioned, it's definitely recommended for people who want to preserve the ejaculatory function. So far, studies have demonstrated that is preserved. The NICE guidelines, they are more bold. They say that you can go up to 100 mils if you want to, without an obstructing lobe. Coming from my experience, of course, other speakers may disagree, but it does seem to be much more favorable. if there is no presence of a huge lobe. There are some tricks, but it's not for the present time to mention when you're doing the cystoscopy, how to get yourself away from traps and over-treating the bladder neck, which is something that we do not want. NICE guidelines gave an age limit as well of 50 years or older. And the AUA guidelines, again, mentioning that is a surgical, minimally invasive surgical treatment that can certainly be considered, especially for people who are very keen on preserving ejaculatory function and very conscious of their erectile function as well. This is the data so far. As you can see, as years go by, there's more and more cumulative knowledge on this technology. There's quite a few a couple of randomized studies, but as you can see, we're talking about almost 100,000 patients treated and almost 500,000 implants delivered. So it looks like there's a lot of centers in the UK that offer the service now, even under local anesthetic as a one-stop ambulatory setting, and it's gaining more and more ground as years go by. This is the study from Prof. Weber in Texas, which was it was the giant, the shoulders on which I stood up when I set up the service in Fife. It's called the LIFT study. They presented the 5-year results. They have been updating the data as they were collecting it. And what these showed from 19 centers in North America and Australia is the durability, as you can see, of the results. For 5 years, the IPSS, after decreasing initially following treatment, basically it remains stable along the time of the period that the study was run. This is the Eurolift compared to other minimally invasive treatments and the so-called gold standard TURP, which I disagree. I don't think TURP should be called the gold standard anymore. And as you can see, retreatment rates are certainly comparable. Again, some more data. As you can see, again, the so-called TURP compared to a gold standard treatment compared to the Eurolift. And when it comes to the first even month of the treatment, there's a rapid alleviation of symptoms. And as the months go by, this study is for 12 months, they remain the same. So following a very rapid alleviation, improvement of symptoms, then following the curves, you see that they end up basically in the same point. So patients feel much better, much sooner. Now we're moving on a little bit away from the clinical trial, which are making very controlled. There's some studies that were run into a so-called real world, and there were almost 1,400 cases recorded. And on those, there were people included with retention and IPSS and AIDS, but they were way a little bit above and beyond the very confined and airtight limits of a study. And again, in this 2-year data collection that is demonstrated here, the IPSS score in all patient groups, those who had a baseline retention, urinary retention or not, were the same, as you can see. Now, what happens with retention, which is one of the main questions? Of course, that was one study. They showed in this non-clinical setting that, in a clinical trial that it can work, but this Hansen Blood, their Ollie Case and the team, they concentrate specifically on the acute urinary retention patients, and they are receiving a treatment of Eurolift after having failed TWOX. The study was called PULSAR, and they have presented the data, which was certainly very encouraging. Basically, this patient selection were, in terms of prostate size and age, are not big surprises, about 100 grams, 50 years old. But the difference now was more than one failed TWOC and being on oral medication. The primary assessment was trying to take the catheter out in about 3 days after delivering the Eurolift implants, and again with a history of retention, and following them up with questionnaires and maximum flow measurements afterward. Basically, as you can see, age-wise and prostate size-wise, they went further, higher and beyond the previous studies. And what they have showed is that 67%, there it is, 67% of the patients were catheter-free by 1 month, and 79, almost 80% of them by 3 months, again, with a history of retention. Of course, they did have treatments. Down there, they had 3 patients, they received other modalities, and 2 of them had a repeat of the Eurolift. I will just go sail through safety features of the Eurolift. Very good question, of course. As Hassim mentioned before, people who want to have either before or after, they have a history of prostate cancer in the family, or they want to be followed up for prostate cancer in the future. How does Eurolift come into this equation? This is an MRI image of the implants, showing, of course, the urethral tract there. It has been investigated, and more data is collected as we move on. Basically, the conclusion was that the Eurolift artifact, the implant artifacts, are not interfering with the areas where suspicions of cancer are raised. There is an MRI PUL study that has been found in the literature, and that demonstrates exactly what we said, basically, that there is no artifact on MRI that can affect basically our clinical judgment once patient has received the implants and wishes to be investigated for cancer. Now, the MRI itself, apart from the images, the MRI itself is considered to be compatible, the Eurolift rather, compatible to the MRI, up to 3 Teslas, which is more than enough to diagnose cancer. And the demonstration, the data that was found from studies showed that there was only a 2.4 degrees increase of the temperature of the implants after 15 minutes of imaging of the MRI, continuous imaging of the MRI, which was considered safe. So for both reasons, as we say our patients as well, certainly not the end of the line if you have a Eurolift for prostate cancer investigations. Of course, Prof. Reber, as we said, moving on a little bit very quickly to the sexual function, they have demonstrated that certainly in follow-up, it can preserve sexual function, even for 2 months, for 2 years following Eurolift treatment. The so-called MedLift study, they managed to demonstrate the same results even with the presence of a median lobe. Again, that will be subject to patients and surgeon discussion and the surgeon's views on the matter, and that is something that doesn't come under strict guidance at the moment. I will just finish with what we have been where we have been established in 5. This is Prof. McQueenie, which is the former president of BADS, which is very catchy for the British Association of Day Surgery. He visited 5 a couple of years ago, and what struck me was that what he said is, if you give the patients a bed, they will use it. So give them a chair instead. This is something unforgettable for me, because we did exactly that in 5. People don't need beds. If you just give them a bed, they will use it and lie down. So if you have a quick turnout in a day stay unit, in a clinical setting, even under local anesthetic, why not use it? And what comes to mind more than the Eurolift procedure? So this is another poster that I found in one of our lifts, adapted from Addenbrooke's, basically saying that you don't have to take your clothes off. Well, it was an exaggeration to get treated, but there is some data there about loss of muscle mass, more than 10%, if you stay 1 week in bed rest. Obviously, that comes for different specialties, maybe geriatrics, but in essence, we do not want people to be in bed. This is our unit in 5. Left and right are consultation rooms. I will show you very briefly that it's also a treatment room. It's nothing more than half of the size of an outpatient department with these randomly posing nurse over there. This is the bay, which is first the admission bay and the recovery. 4 beds and can be modified more if you wish. So as you can see, that all that it takes. We go in the morning, we see the patients, we consent them, and then we bring them to this room where we only use lightly chilled Instilla gel, which we save in a fridge since morning. We give about 20 minutes, and we just leave them to relax for a little while, and then we take them to this room, which we also use for flexes and urodynamics, and this is the treatment room. This is how easy it can be, and that's where we do the Eurolift under local anesthetic. So after that, they're going back. This is the room with the staff being there. As you can see, the so-called scrub nurse is just using sterile gloves and an apron, and that's it. So it's a totally transformed into an ambulatory case, and then they're going back to the same room where they are admitted, and moving on after a few hours after being admitted, moving on back home. Of course, with the main question being where they're going to go back to the golf course. So with this setting, we managed to move away from this theater here, where we started the Eurolift and general anesthetic, to the clinic that I have shown. This is something that we're blowing our trumpet a little bit. It's been adapted by NICE, but yes, Eurolift can be treated, BPO, as they call it, can be treated as an ambulatory, in an ambulatory setting, outpatient setting, under local anesthetic. We have a very big interest in simulation courses for BPH, but this is not something that we can expand at the moment. We're very happy to have trainees over there to train and put a hands-on on BPH treatments. And also, it's been adapted very proudly by the University of Edinburgh, the minimally invasive treatments as a new section. This is the end of my presentation for now. Of course, there will be time for questions later. Thank you very much. Thank you, Anand.
Thank you, Petros. That's a fantastic presentation and setting the starting stones for the rest of the session. I'm very much interested with your concepts of doing the Eurolift under local anesthesia and also the ambulatory settings. I think the day will come that your ambulatory unit may not need any beds and we can just have chairs.
Yes,
and,
just chairs.
Yeah, that's the future. Very nice.
Mm-hmm.
Next, I will call upon Giampaolo. He is the consultant from Italy. He is going to tell us about Resume. Resume is the energy source which is almost like for Eurolift, and the patient population is almost the same. And let's hear from him.
Good morning, everyone. And so we're going to share the screen. So we talk about the Resume, the world's costliest kettle. So during the last 10 years, the number of TURPs performed, as you can see in this paper, have shown a steady decline from 81% of all surgery for benign prostatic hyperplasia in the USA in 1999 to only 39% by 2005. On the other hand, all minimally invasive surgical treatment, the so-called MISTs, and total surgery for BPH have constantly increased. Among MISTs, in 2015 and introduced in Europe in 2018, at present, we have one RCT versus sham treatment reported in the literature with a maximum follow-up of 5 years. What is the basic principle of Resume? The Resume system uses radio frequency power to create thermal energy in form of water vapor, which in turn deposits the stored thermal energy when the steam phase shifts to liquid upon cell contact. Due to the convective properties of water vapor, the steam disperses rapidly and homogeneously through tissue interstices and releases this energy, affecting cell necrosis. As Eurolift can be performed in a office-based setting with minimal pain management. The physical principle, so we know that 540 calories per milliliter of stored thermal energy is released during phase change from water vapor to water. We also know that more than 70 degrees, at a temperature of more than 70 degrees, cell death is immediate and irreversible. During a resume treatment, 103 degrees water vapor is convectively delivered into 37 degrees prostate tissue. So the temperature of tissue increases to 70 degrees over the course of 9-second treatment, resulting in instantaneous cell death. Another interesting point is that convective thermal energy is delivered homogeneously within the targeted area, as shown in the picture on your left, and does not go beyond the transition zone boundary. On the other hand, as shown in the picture on your right, the conductive heat transfer cell to cell, so a non-uniform heat gradient results in cells near source being heated substantially more than those far away. So in this case, conductive heat of prostate capsule may also occur. As reported in this paper by Dixon, the thermal energy is delivered to the Mcqs transition zone of the prostate. That is the area we want to treat. In this study, patients were scheduled for simple prostatectomy, but they were treated the week before with a resume system. So the extirpated adenomas, we see the pictures here, there were 7 specimens, were grossly examined, followed the whole mount sectioning and staining with TTC in order to evaluate the thermal ablation. TTC, what does TTC do? TTC stains viable tissue with healthy metabolic enzymes as a bright red color. So the bright red color of the adenoma is a viable tissue, while irreversibly damaged tissue with no metabolic enzymes does not take up stain and remains its natural tan color, the transition zone in the middle. So we can also see that the maximum lesion size reported was 2.1 per 2.8 centimeters, as shown in the 7 specimens. Another interesting point that the urethra was preserved, as shown in the H&E histologic staining. We can see a general preservation of the prostatic urethral epithelium, and moreover, there was no carbonization or heat fixation observed in the excised tissue. In the same paper, Dixon and colleagues treated other 15 patients only with resume treatment. In this case, as a week from the procedure, we can see an MRI prostatic gadolinium defect observed in all patients, mimicking basically what was observed using the TTC staining on adenomectomy whole mount specimens. At 6 months, the thermal lesion resolved and the transition zone volume reduced of nearly 40%, while the whole prostate volume reduced of nearly 30%. As also shown here in the rendering image, you can see the whole prostate reduced of 30%, and the central part of the transition zone, the green color and the blue color, reduced of 40%. So this is a video of the procedure. It's a very simple procedure. It uses a cystoscope. We can say that a learning curve of 5 to 10 cases is probably enough. The more you do, of course, the better, as usual, but after 10 procedures, you're pretty confident. So with a dedicated cystoscope, we navigate into the urethra. The distance from the tip of the optic to the tip of the instrument measures 0 length from the bladder neck to the verumontanum. So we know that we have to do an injection each 1 centimeter approximately, This is not strict. It doesn't do any harm. Sorry, the video. We don't do any harm if we do more injection. Another interesting point is, as you can see, the procedure is completely bloodless, and the tissue turns suddenly pale and avascular. In case of the median lobe, 1 to 3 injections can be performed. So I can skip at the end of the video so we can see the final result. You can see here the prostate is avascular and paler than before. So this is the case, the images of the same patient. This patient has a preoperative Qmax of 6 milliliters and a PVR of 150 cc. At 2-month follow-up, the prostatic fossa is wide open and the postoperative Qmax is 21 milliliters per second and the PVR negligible. This is another case. This case was a 90 cc prostate with an IPP grade 3. And at 3 months, we can see the median lobe. This is a retrograde lesion with a cystoscope, with a flexible cystoscope. The median lobe is shrinked. The anterior part of the prostate is not treated, and you can see the adenoma is still there. And interestingly, this is the area, the verumontanum, the so-called ejaculatory cap is preserved, so is the ejaculation. So what does the literature say? In the pivotal study of Mcqs and colleagues, they present, this paper is ahead of print, they present in a number of April of the Journal of Urology, they present 5 years outcome of a multi-center randomized sham control trial. The demographic and patient characteristics are here reported, a total of 197 subjects with more than 50 years of age, IPSS more than 13, Qmax less than 15, prostate volume between 30 and 80 cc's, were randomized and followed for 5 years. These are the outcomes. They report a significant improvement of LUTS at 3 months post-thermal therapy that remained durable through 5 years in the treatment group. They reported a reduction of IPSS of 48%, an increase of quality of life of 45%, Qmax improved 44%, and BPH impact index decreased 48%. When the median lobe was identified and treated, IPSS and Qmax showed a significantly better improvement than in those cases when it was only identified but not treated, as shown here in this paper. These are the adverse events. In 57% of the cases, there's no adverse events, but they're typically mild to moderate and self-limiting within 3 weeks. Most common adverse events are listed here. They're dysuria, gross hematuria, hematospermia, frequency, retention, and urgency, all grade 1 according to Clavian-Dildo classification. About the long-term efficacy, the surgical retreatment rate was 4.4% at 5 years. Of those cases, 2 patients underwent TURP and 2 patients were retreated with Rezum. And at 5 years, 11.1% returned to medical treatment. About the sexual outcomes, the same in the literature. There's no device or procedure-related sexual dysfunction or sustained de novo erectile dysfunction. In our experience, on a multi-center study on 135 patients, we also observed a slight but statistically significant increase of the IAF-5 score from baseline to 6 months. A special consideration should be done to the catheterization. The catheterization time after Rezum ranges between 0 to 4 days. According to the literature, in our experience, we prudentially opted for a longer catheterization time of 7 days in order to avoid acute urinary retention. The person has a special ultra-thin self-removing catheter that allows urine to bypass around the catheter. This is called a XIM. This provides minor discomfort and especially allows complete urinary continence and spontaneous urination. It could be left in place for a month. What does resume may be offered to patients with small to medium-sized prostate. Patients should be counseled regarding efficacy and retreatment rates, and it should be offered to eligible patients who desire to preserve erectile and ejaculatory function. So basically, ideally, in terms of invasiveness and efficacy, resume locates midway between medical therapy and definitive surgery. In terms of cost, as showed in this paper by Ulkeher, basically in this graph, they measured the efficacy with the average IPSS at 2 years and the cost, and the best position would be down and on the right. As you can see, the resume treatment performs pretty well. Indeed, it outperforms most MISTs in terms of cost and efficacy, whereas when compared to 2RPM or green laser, shows less efficacy but minor cost at 2 years. The decision-making process, we will discuss it widely later on. At the moment, we have like a portfolio of options. We have to take into account several parameters going from clinical conditions like medical therapy, anticoagulation, or antiplatelet therapy, and prostate volume is an important parameter to decide what type of treatment we want to go for, and also sequelae and sexual function, or if the patient can undergo general anesthesia. In this case, MIST definitely can play a role. So in conclusion, after having weighed efficacy, invasiveness, cost, skill set, we can make our decision what treatment to offer to the patient. And regarding the resume, we can say that is an office-based procedure that requires local anesthesia to mild sedation, has a short learning curve, 5 to 10 cases, showed a good efficacy in terms of improvement of Qmax, IPSS, quality of life, a low complication rate, generally multi-moderate and self-resolving within 3 weeks, reasonable durability, although it needs longer follow-up, and a high rate of preservation of sexual and ejaculatory function. It should be used for prostate volume less than 80 cc, but also in this case, the volume is not so strict. There are papers that report with a very short follow-up cases of larger prostate. Thank you.
Thank you, Giampaolo. That's a nice presentation. I think regarding the resume and Eurolift, the main thing is we are waiting for like 10-year, 15-year long-term outcomes. That's the main thing. And once that box is ticked, I'm sure they are supposed to stay forever. Nice presentation. I'm very excited with your concept of using that EXIM short catheter. That's a nice concept. Even though it's licensed for 30 days, I think you will be removing it in 5 to 7 days, isn't it?
Yes, yes. It's important you don't have microhematuria, because otherwise if you have clots, they can block the system. But in these minimally invasive treatments, normally the hematuria is really mild.
Yeah, thank you very much. The next talk is by Neil Barber. We are going to discuss the iTint. I'm going to share his screen because he sent us the presentation. iTint is such a very, very simple concept, and sometimes it's quite surprising and very hard to believe that is it possible to have such a very simple equipment to give deobstruction and good cavity for prostate. Let's see what he has. Just give me a minute.
I'd like to thank Ananda for the kind invitation to speak today at this iTrue meeting regarding the iTIN device, the temporary implantable nitinol device. We're entering a world now where there are numerous options in terms of the surgical management of symptomatic BPH. And over the last few years, we've seen a great deal of interest in the so-called minimally invasive surgical treatments. This is kicked off with the prostatic urethral lift procedure using the Eurolift implants. Also involves prostatic artery embolization, as well as Rezoom, which I think you've heard about. And entering this market space then is the iTIN device. So what is the iTIN device? It's a device which is placed in the prostatic urethra across the bladder neck. It's aiming to for 5 to 7 days as an ambulatory procedure. It is made up of 3 struts which create longitudinal ischemic incisions through the bladder neck and prostate, remodeling the prostatic urethra in an effort to relieve obstruction, improve urinary flow, and improve symptoms. The 3 nitinol struts are at 12, 5, and 7 o'clock, and there's an anchoring leaflet at 6 o'clock, which is used to hold the device in position during the 5 to 7 days of placement. There is also a polyester suture anchored to the distal part of the device, which is used for retrieval. This image demonstrates the incisions made by the device at 7, 12, and 5 o'clock, and this widely opens up the bladder neck and the prostatic urethra. It's not a new device, and indeed the early data was submitted to the Interventional Procedures Committee of NICE in the UK back in 2018, with guidance coming back in 2019. In essence, it was placed in the experimental category in that guidance, and really what they were after was further information from randomized trials, a greater idea about who and what patients were suitable for this, both in terms of prostate size and indeed in terms of the presence or otherwise of a middle lobe, the degree of symptom and flow improvements both in the short and long term, evidence of reintervention rates, and particularly more standard measures of impact upon sexual function. So what data do we have now in 2021? Essentially, there are 3 studies have been around for a while, plus a 4th one which is just published, which we'll come on to. These 3 studies involve men of expected age with smaller sized prostates, but with significant symptoms, flow rate suggested obstruction, and good bladder emptying, that is probably good detrusor function. First study was called MT01, and this was a single-centered study using the first generation of the device in Turin in Italy. And we can see here that the device treatment led to a significant improvement in IPSS, which is reasonably maintained out to 3 years, as well as flow rate, much in line with the level of improvements that we see with the other minimally invasive surgical treatments of Eurolift and Rezoom. The second study was a multi-centered pan-European trial called MT02, and there's this one which I was involved in as a UK site. Indeed, there were 8 sites across Europe and Hong Kong, and 80 patients were enrolled with a mean age of 60, but again, relatively small prostates with a mean volume of 39 mils. There were the usual inclusion-exclusion criteria, as well as functional endpoint results. We can see here that once again we see a significant improvement in both IPSS and flow rate maintained out to 3 years of the study, again in line with both the Eurolift and Rezoom outcome data. We see similar improvements in quality of life as well as post-void residual volume. Effect on sexual function was only assessed using yes-no questions, but in that study, all patients reported maintenance of normal antegrade ejaculation and erectile function. The most common complications were, whilst the device was in place, being hematuria and urgency, with a degree of discomfort and dysuria as you might expect. There was a low level of retention and urinary tract infections. At the end of that study, they did do a failure analysis to look at the 81 patients and see who did well and who did badly, and if there were particular reasons why those patients didn't do so well from the treatment. Nearly 60% of the people who did badly or considered failures had significant middle lobes. Indeed, it was only this variable that was found to influence the likelihood of success of the treatment. MTO6 was another pan-European multi-centre study, and not only was this looking to once again examine the effect in terms of flow and symptom improvement of the device, but also more specifically get more standard types of data regarding impact upon sexual function. 70 patients were recruited across the sites, and we see in the table there the same kind of level of improvements in flow and symptoms that we've seen previously. What is interesting is that on the left there, we see that on average, patients return to daily life 4 days following the retrieval procedure, which means a return to normal activity some 9 to 11 days following the insertion of the device, i.e. a really rapid return to normal activity compared to any other treatment option around. MTO3 then is the latest trial. And this is the randomized trial against sham required by the FDA to gain approval. This was a multi-centered trial in the US with 185 patients recruited and randomized. And it is the publication of data from this study which led to FDA de novo classification for iTind in February of 2020. This has now been published in the Gold Journal. There were patients who were over 50 years of age and were randomized 2-to-1 from iTind to sham. And the results demonstrated similar kinds of improvement in the IPSS with a decrease of 9.25 and an increase of 3.5 mils per second in terms of flow rate. Adverse events were mild and transient. And in fact, there was little difference really between both the arms. And in particular, there was no de novo ejaculatory or erectile dysfunction recorded. So we now have a whole number of trials, single centre, but more multi-centre, examining the outcome of treatment with the iTind device. And we can see here, as we overlay them, that they have the same kind of level of improvements in IPSS and flow rate, which means that the effect of the device in terms of improving symptoms is reproducible across trials and across multiple sites. We saw in the 3-year studies a durable improvement with an under 9% surgical retreatment rate, which certainly is in line with something like Eurolift. Here are the publications as relate to those trials. So what can we conclude then? We can conclude that the iTind is a minimally invasive surgical treatment. It is added to the armamentarium available along with Eurolift, Resume, and indeed prostatic artery embolization. We have multiple trials, many of them multi-centered, demonstrating reproducibility of outcome and durability at least out to 3 years with a relatively low reoperation rate. And we have good evidence now that these improvements apparently carry no risk in terms of negative impact upon sexual function, be it in terms of ejaculatory function or impact upon erectile function. So in 2021, we then have the evidence to go back to NICE to answer the questions they had regarding the data to lift it from the experimental category to a more accepted treatment option. And indeed, this data has been resubmitted. We look forward to the publication from the NICE Interventional Procedures Committee regarding their latest guidance. I apologise for the very quick sprint through all aspects of iTind, but I think you will agree that it certainly seems to represent a real option for men who want to have a minimally invasive treatment to improve their symptoms, yet preserve their sexual function. In particular, for instance, may want to avoid the placement of implants or face the prospect of a post-operative urinary catheter. I'm afraid I won't be able to attend the meeting in person, so I won't answer any questions regarding the device, but I'm very happy to do so separately. Again, many thanks for the kind invitation, and I hope you enjoy the meeting.
That was a very nice presentation from Neil Barber. The advantage of Neil is he is like master of everything. They say you can't be a master of all the tricks, but Neil is good in Eurolift, resume, aquablation, iTint, and he is the main person for the BPH. Next we have Sachin. Sachin is our urology interventionist from Southampton, and he's got prostatic artery embolization. And he's the person who's going to steal all our BPH techniques towards the intervention radiologist. Welcome, Sachin.
Thank you, Ananda. And thank you very much to the iTrue group for inviting me to talk to you as a non-urologist on prostate artery embolization. And I can assure you I'm not going to be stealing your patients. These are my disclosures. So we're going to have a brief overview of the evidence for PAE, some of the workup, patient selection, the treatment pathway, and I'll show you a bit about the PAE procedure itself. So we've moved on now from PAE being the new kid on the block with no evidence. We've now got some good evidence, level 1 evidence for prostate artery embolization. Multiple studies, over 400 peer-reviewed articles, 5 randomized controlled trials, data from a mid and long-term follow-up in over 1,000 patients. We've got randomized controlled trials versus some of the other techniques mentioned today and that we're going to talk about today, and randomized controlled trials against sham procedures. And essentially, the evidence tells us that in early, mid, and long-term follow-up of PAE, the following are significantly improved: IPSS, quality of life, prostate volume, post-void residual, and Qmax. PSA is reduced or remains stable. There's a high safety profile with a low rate of complications, no significant erectile disorder or urinary incontinence, and it's a good alternative to medications and surgery, especially in the elderly with comorbidities. We've got consensus from interventional radiology societies around the world, and we've also got some guidance now. So we've got NICE guidance in the UK, which, importantly says that this procedure is a technical procedure, should be performed by an interventional radiologist who's got experience in and training in prostate artery embolization. And key 1.2, patient selection should be done by a urologist and an interventional radiologist. And that's very much how we work in Southampton. It's also come onto the European guidelines, and where they have got some recommendations for prostate artery embolization, although the evidence is weaker compared to some of the other missed treatments. We still have no recommendations on the American guidelines. So in terms of a prostate artery workup, a typically initial urology workup, as we've discussed, with the basic things. At Southampton, all of our patients do have urodynamics prior to prostate artery embolization to confirm bladder outflow obstruction. However, this is not done in all centres in the UK. Anecdotally, we found that those patients who have high Abrahams-Griffith scores on the urodynamics is a good predictor of IPSS reduction following prostate artery embolization. So we generally referred patients with an IPSS of 8 or greater. In terms of assessment, as you know, BPO or BPH is just one cause of LUTS, of which there are many, and the urologist is best placed to make the initial assessment and then refer as appropriate. In terms of radiology workup, all our patients undergo a CT angiography, which is essential prior to PAE. In our experience, it reduces significant operator time and patient dose during the procedure, and it allows detection of the prostate arteries and potential anastomoses, which is one of the cautions when performing prostate artery embolization. It also allows us to exclude unsuitable patients with heavily calcified or occluded arteries, small glands, and if we can't see the prostate arteries on the CT, it's unlikely that we're going to be able to get into them angiographically. We've looked at this at Southampton. We looked at 120 patients at 240 hemiprostates. So CTA very successful at detecting the prostate artery origin, of which there can be many, and very specific in detecting the presence of anastomosis, which is key to avoid non-target embolization during the procedure. This is an example of a CTA, so we've got very dense contrast in the aorta here, and what we want to see is a nice hypervascular prostate. I'll just take you back here with prostate arteries entering both sides. What we do is we follow we find the prostate artery going into the prostate, and then we trace it back to find its origin. So which patients are best suited for prostate artery embolization? There's a lot of research that's gone on into this, and we want to select the best patients because we want to have the best outcomes. So generally, patients with higher total prostate volume and higher central gland volumes are associated with better outcomes. And our ROPE data from the UK correlates with other studies that larger prostates greater than 80 cc have favorable outcomes compared to smaller glands. In terms of the zonal volume, so patients with a greater central zone volume, greater than 45%, have better outcomes following prostate artery embolization. In terms of composition and histology, these are some MRI images following prostate artery embolization on the left, and this is after on the right. And you can see here devascularization of these large adenomatous nodules in the prostate. And that corresponds with a better result. So adenomatous dominant BPH is a positive predictor for IPSS improvement at 12 months and continued to 24 months. In terms of median lobe, so there's some conflicting evidence. There's some evidence that the intraprostatic protrusion can be reduced following PAE. However, in our experience and general consensus is that enlarged median lobe can result in a poorer outcome and may require resection post-PAE. And we've had some patients that have had PAE and they've gone on to have a limited median lobe resection. And this is especially the case when the median lobe hypertrophy is greater than the lateral lobe and if there is asymmetrical hypertrophy. There's a concern that the patients get a sort of ball valve type of obstruction with altering of the prostatic urethral angle with the alteration in the funneling of the urine. Which symptoms benefit best from PAE? So generally, we found that the storage symptoms are the most severe symptom in our group, and PAE was most consistent when improving storage symptoms compared to the avoiding symptoms, but does improve all the symptoms across the IPSS spectrum. Other factors we've looked at, so this is from the ROPE cohort. We've looked at all these data and done a multivariate analysis on other factors such as hypertension, diabetes, and coronary artery disease, and we found that patients without these comorbidities had the greatest improvement in IPSS. Why is this? Probably because small vessel disease prevents particles from reaching distally. Also, small vessel disease may cause a stromal pattern rather than the adenomatous pattern of BPH. And calcified atheromatous vessels are not good for us and limit our technical success in these patients. So who is your ideal PAE candidate? It's someone that's informed, i.e. someone less than 70, someone that's failed medication or wants to stop them or has side effects, IPSS greater than 8. We don't want marked arteriopaths. We want reasonably healthy pelvic vessels to give us the best chance of getting into them. We want proven bladder outflow obstruction with strong detrusor function. We want large prostates, greater than 80 better, but at least greater than 50. We want patients who are sexually active and want to remain so. No significant median lobe, no bladder stones, which we tend to remove prior to PAE, and prostate cancer excluded using the PSA. Ideally, adenomatous dominant BPH with a high central gland volume. And who's a poor candidate, which is really the opposite to all of those. We want to make sure that we're selecting the best patients. So what are the controversies with PAE? Some may say, what's the long-term evidence? Well, we've got some long-term evidence now. There's increasing evidence for good long-term outcomes. We've got evidence suggesting 80% clinical success rate at 1 year with a 2% recurrence after that. And in our patient cohort, up to 78% of patients continue to have a response. And we've got a 23% recurrence rate at a median of 72-month follow-up. So there is long-term data out there. In terms of radiation, I often get asked about this. So when we first started out in the UK, there's a definite learning curve for this procedure. The more you do, the better you get, better your radiation doses are for yourself and for your patients. But overall, in the UK ROPE, which was the first study where patients where doctors were performing prostate artery embolization, the additional risk was less than 1%, lifetime cancer risk. So that's quite low. But there is significant intraoperative variability, and this should be performed in high volume centers. In terms of the sexual side effects, very good. There was some dry ejaculate reported in the UK ROPE and the Swiss randomized controlled trial, but this mainly was due to pre-existing medications. In our current practice and in the most of the literature, there's no effect on sexual function or ejaculation. So this is a nice algorithm that I've seen in the BGUI, which separates patients who are fit for surgery, who are indicated for invasive treatment, fit for surgery, either on anticoagulation or unfit for surgery, and it gives us a nice differentiation of the treatments available. So how do we do this in the UK? Patients generally seen by urologists, referred for a CT, and have a radiology appointment with us ourselves. We perform the PAE and the follow-up is combined. It's a day case procedure, no need for a catheter, 1 to 2 hours in the room, depending on how easy it is or difficult it is to get into the arteries, 4 to 6 hours recovery, patients got home the same day, very low side effect profile. Planning is very important. We want to make sure that we've drawn these diagrams before so we know exactly where the prostate arteries come off from using our CT to give us the best chance of success. So this is nice pictures here where we can identify where the prostate arteries are coming off. We generally use femoral access, but there is a new vogue towards radial access, although we're limited by the length of the equipment that we have to go from the wrist. Various catheters and microcatheters to allow us to catheterize the prostate arteries, small micro wires. This is an example where we use various angles to open up the prostate arteries and the internal iliac arteries. And we use various shaped catheters and wires to get into these prostate arteries. Once we're in the arteries, we tend to do AP and lateral projections to confirm that we are supplying the prostate. We do something called a rotational CT or a dyna CT. So before I come on to that, we often see sometimes collateral, so collateral here going to join the pudendal artery, and we can protectively coil these blood vessels to enable us to perform safe embolization. One of the things we commonly do for every patient is a cone beam CT, which is so once we're in the prostate artery with our microcatheter, the machine spins around and we inject contrast at a relatively low rate, and this allows us to see that we've opacified the prostate correctly and that there's going to be no non-target embolization. So you can see here nice opacification of the hemiprostate and then no contrast anywhere else. So it gives us more confidence to embolize safely, and you can get good correlation between the angiographic images and cone beam CTs. In terms of embolization, how do we do it? We can't just put coils in the artery. We need to put particles in which are going to cause necrosis of these nodules in the prostate. The particles are not small enough to damage the urethra, but they need to be small enough. Usually 100 to 300 micron is what the current vogue is for use around the world. And this is what it looks like afterwards. So once we've embolized the artery, we see the contrast going in, but it's not going any further into the prostate. So the summary is we've got level 1 evidence now. It's approved by certain societies around the world, so NICE and the European Urological Society. The controversies have been addressed, and PAE adds to the therapeutic armamentarium in the management of LUTS, which is an increasing problem worldwide. Patient selection is key, as is collaboration with urology. I don't think this is something which interventional radiologists should be doing independently. The best patients are those with a gland greater than 80 cc and who want to preserve their sexual function. And I think a one-stop approach to BPH where urologists can offer all the available things on the menu is best for the patients. Thank you very much once again for inviting me.
Thank you, Sachin. That was a very good presentation. In fact, from the urologist point of view, we are so happy to see those images, which gives us an idea. You have proved that prostatic artery embolization has a place for future, and there is a place for collaboration. Thank you very much. Next, we have Maya Harris. She is the consultant urologist from Warwickshire. She is going to discuss with us the last minimally invasive energy source, which is the green light.
Hello, everyone. Many thanks for inviting me to present at this meeting. And I will start sharing my screen just now. And start presentation.
Just on your left.
Yeah. Can you see my screen?
Yes, Maya.
We can see your screen. Please click on slide 4. Just next to the animation.
Yes.
Above menu.
Slide 4. There we are.
Done.
Sorry, I'm still quite new to this technology. So I'm going to talk to you about green light laser. And first, a little bit of a technical detail. It's a side-firing laser, which was first developed by AMS, but now is owned by Boston Scientific. And the modern machine is 180 watts. And it works by generating very high temperatures, which turn the prostate tissue into vapor. It also has a very small penetration depth, so you don't get charring and subsequent fibrosis. So that's a difference with some previous lasers used. So why use green light? I must admit to you all that I'm a great fan of this technology. You can see here on a picture a comparison of irrigation fluid after green light and TURP. So it causes much less bleeding, and there is no need for postoperative irrigation. And also the patient could have a catheter much earlier out. And also I like that there is no prostatic chips, so you don't need to wash them out or contact the patient with a histology subsequently. The use of a green light really is based on a paper which is now about 10 years old. Paper is called Goliath study, and it has shown that a green light laser is non-inferior to TURP in respect of IPSS decline postoperatively and also flow rate. But doing green light laser results in shorter hospital stay and less complications. So it has a favorable safety profile, and it has been NICE approved. I've been doing green light laser since 2015, and I would like to share with you some technical tips. I usually give gentamicin at induction and also tranexamic acid, so that results in practically bloodless field. The patient is positioned with their head up, and all the anesthetists are your best friends because of it, as frequently unfit patients undergo this procedure, and it's much easier for them to give anesthetic. The head up position is useful as you generate bubbles and then they escape into the bladder. This is different to TURP, as in TURP you generate chips, and those those are heavier, so you need a patient head down. So to do a green light laser, you'll get a fiber, and the tip of a fiber gets so hot with a modern machine that it needs to be connected to its own irrigation system. And you get two settings, vapor, which is a high energy, and coagulation, which is a lower energy. I usually start the procedure by marking out a prostate by the Vero and also pre-coagulating any large mucosal vessels. The interesting fact about green light laser, you can operate almost bloodlessly until you hit a large vessel. So I find it useful to have a bipolar diathermy probe, as it's not easy to stop bleeding from a large vessel just using green light laser. And with a bipolar diathermy probe, you can easily pass the probe without changing the scope and irrigation fluid and cauterize troublesome bleeder. So I would like to discuss briefly what is the role of green light laser with all the other various technologies. Certainly, it is useful for larger prostates, and as you experience advance, you tackle bigger and bigger prostates. It also independent of a shape to a degree, and really various considerations need to be taken kept in mind when you are discussing procedures for BPO in these days. So certainly green light laser is for an older patient who perhaps is not so concerned about possibility of a retrograde ejaculation after the procedure, and who wants a good flow following the procedure. But of course, some younger patients choose green light laser as, in my opinion, it is more definitive and lasting than less invasive, minimally invasive options such as Eurolift, Resume, and iTrue. I also would like to briefly mention about the cost effectiveness, and with a green light laser, you get more IPSS improvement for the cost, according to this study. So in conclusion, I would like to say that green light laser prostatectomy would continue to have a role in treatment of BPH as a part of a portfolio, especially for older patients with comorbidities and larger prostates and perhaps retention. Thank you for your attention, and please ask questions and comments. Comment on a Twitter where my handle is Urologist Maya.
Thank you, Maya. That's a very nice energy source to complete our minimally invasive surgical techniques portfolio. Now we are heading towards the big brothers. The first major energy source is the holmium laser enucleation from Tanuj. Tanuj is a senior consultant and head of institute from Faridabad. Welcome, Tanuj.
Thank you, Dr. Anand. Am I audible clearly?
Yes.
Yeah. So thank you, iTrue Group, for this opportunity. So I'll be talking about Holap, mainly about the technique and outcomes from a resident's perspective. So Holap is now a time-tested modality, with first reports coming from Dr. Peter Gilling in 1995 and 1998. And ever since, there has been an ever-growing interest with many published art papers and more than 50 meta-analysis and review articles. Of course, there is a learning curve associated with Holap, which is considered to be steep, but mentorship is very important. One has to do at least 20 cases in a short duration of time to understand the technique. And the difficulty one faces are loss of plane, bleeding and hemostasis, technique of proper morcellation, vision during morcellation, and risk of bladder injury. The main thing we need to do is a high power holmium laser, which has excellent tissue cutting effect, achieves good hemostasis. One of the advantages with this laser is that we can use reusable fibers, making it more cost effective, and it is very versatile. We can use it for prostatectomies, OIU, lithotripsy, endopelotomies, and urothelial tumors as well. These are the instruments I use at my setup, very basic instrument set. These are the laser working elements. This is the one from Karl Stores, and this one is from an Indian manufacturer, which is called a laser bridge. This is a routine resectoscope sheath. This is the morcelloscope. This is the adapter that we need to attach the morcelloscope to this sheath. This is our telescope and the morcellator blade assembly. So Holap is mainly a combination of enucleation and morcellation. When we talk about enucleation, there are three main techniques: the 3-lobe technique, the 2-lobe technique, and the unblock technique. In the 3-lobe technique, we make laser incisions at 5 o'clock, 7 o'clock, and 12 o'clock positions, and then we retrogradely enucleate the median lobe and lateral lobes. In 2-lobe technique, we make incisions at 6 and 12 o'clock positions in the fossa, and then we retrogradely enucleate the left and right lateral lobes with the median lobe. And in the unblock technique, we enucleate the entire adenoma as one piece. This can be done by a donut or other techniques. How do we make a choice of the technique? This is more important during initial part of our careers. We use a 3-lobe technique mainly for large glands and when there is a large median lobe. We use the 2-lobe technique when there's a small gland and no median lobe. And for unblock technique, it should be preferred in smaller adenomas initially. However, as you gain experience, you tend to do it for all the prostates. It is to be attempted only after a certain level of expertise. It is very important to understand the technique of Holap that we should know the demarcation between the capsule and adenoma. How I differentiate it is as the capsule is the shiny capsule with transverse fibers and adenoma is the fluffy part of the prostate. Sometimes we might not see the fluffy part, we might see such nodules, but if you are seeing the capsule, shiny transverse fibers next to it, we know we are at the right place. Similarly, in the lower two images, we can clearly see the demarcation between the shiny capsule and the fluffy adenoma. So if we know this plane, we know where we have to dissect. So when we are dissecting, we basically lift the adenoma with the beak of the telescope. That is when these transverse fibers, they get stretched vertically. And these are the vertical fibers that we have to divide with our laser beam. So that's how we go on by doing the enucleation. So talking first about 3-lobe technique, as I mentioned, first we make an incision at 5 o'clock position from the bladder neck till the verumontanum. Then we make another incision at 7 o'clock position from bladder neck till the verumontanum. Then we connect these two incisions in front of the verumontanum. This particular incision can be placed beforehand also. It helps in identifying the capsule. As we connect these two incisions, we go on enucleating the median lobe and it gets pushed into the bladder. Then we rotate our scope, we mark the distal limit anteriorly near the verumontanum, and then we make a antegrade incision from the bladder neck till this distal limit at 12 o'clock position. Once we have done that, we need to release the adenoma from the sphincter. To do that, we make a circular incision at the level of verumontanum. We start from the 6 o'clock to 3 o'clock position, then we rotate the scope and we join this incision from 12 o'clock to 3 o'clock position. This is called as early apical release. And then we make the same incision on the other side from 6 o'clock to 9 o'clock position, and then from 12 o'clock to 9 o'clock position. By doing this, we completely free the adenoma from the sphincter, and that's how we prevent the risk of stress incontinence. Once we have done this, we deepen the same planes, and by joining the 5 o'clock and the 5 o'clock and the 12 o'clock position incisions, we enucleate the left lateral lobe, and by joining the 7 o'clock and the 12 o'clock position incisions, we enucleate the right lateral lobe. I'll just show a small video showing the same technique. So first and foremost step of any enucleation procedure is the cystoscopy. We need to see the landmarks, we need to see the position of the verumontanum, we need to see the anatomy of the median lobe and the lateral lobes. As we go inside, we need to see the position of ureteric orifice, we need to see how far they are from the median lobe, because when we are enucleating the adenoma retrogradely, sometimes we can injure the ureteric orifices as well. Then we rule out any other pathology in the bladder. Once we have done that, we make the 5 o'clock incision. As I said, initially we make it a superficial incision from the bladder neck to the verumontanum. And then we deepen this incision till the capsule, as we can see. So once we see the transverse fibers, we know that we have reached the capsule. Then we make the same incision on the right side at 7 o'clock position. First the initial superficial incision, which is then deepened till the capsule. Then we join these two incisions in front of the verumontanum. Once we have connected these two incisions, we can see the vertical fibers there. We go on dissecting in the same plane, and that's how the median lobe is lifted, and it keeps getting pushed towards the bladder. Once we have reached the bladder neck, we divide the final fibers and the median lobe gets pushed into the bladder. So once we have done this, we come back to the verumontanum and we rotate the scope. So we come back to the verumontanum and we rotate the scope, thereby, because we want to mark a distal limit anteriorly. So we go deep till the capsule here. Once we have done this, we make the 12 o'clock incision from the bladder neck till this distal limit. We can use a sweeping motion here, which helps in dissection of the partial dissection of the adenoma anteriorly. So once we have done this, our 3 incisions are complete. Then we make the apical release incision, what I had mentioned earlier. I will just skip this part because I've shown already. So then we start the enucleation of the lateral lobes. We do this by, as I said, joining the 5 o'clock and the 12 o'clock position incisions. We start from the base and we go laterally. We deepen this incision. So I like to see a halo around the laser beam. That's how I know that I am at the right distance from the plane of dissection. If there's a bleeder, we can just stop the bleeding by defocusing the laser beam, or else we have to change the settings of the laser machine. Then we come from above laterally. So basically we make 2 L-shaped incision above and below, and we join them to make a U-shaped incision, which we keep on deepening. That's how the lateral lobes are pushed into the bladder as they are dissected. So we continue in the same plane. We can see the bladder neck as we are reaching the bladder neck. And then same procedure we follow for the right side enucleation. So the main difference between the 3-lobe and 2-lobe enucleation is the position of incisions. In a 3-lobe, as I mentioned, we make 3 incisions. In 2-lobe technique, we make 2 incisions. This is mainly done for prostates where there is no large median lobe, but even if it is there, one can make a 5 or 7 o'clock position incision instead of 6 o'clock one and do the same thing. But preferably, initially, one should prefer for smaller prostates with, when there's no large median lobe. So we make a 6 o'clock incision till the verumontanum and a 12 o'clock incision from bladder neck till the verumontanum. And then we again release the apex and make a circumferential incision. As we deepen it, both the lateral lobes get pushed into the bladder. So the third technique is the Unblock Technique. I will not show the complete technique here because of paucity of time, but this is how the adenoma appears at the end of a Unblock procedure. We would have enucleated it all around and it would be attached at one small part in the fossa. And once that part is divided, the entire adenoma gets pushed into the bladder. The main advantage the Unblock technique offers us is that we save time during the enucleation. And another advantage I feel personally is that we don't have to go around looking for plane in different incisions. Once we have made the plane, we just go all around in the same plane. So those are the last few fibers of the entire adenoma being divided, and that's how the entire adenoma gets pushed into the bladder, and it can be morcellated out as one piece as well. You don't have to chase lobes. So if we look at studies which have compared the three techniques, they have found that they have similar postoperative outcomes. On-block and two-lobe techniques significantly faster with respect to enucleation time, operation time, and the speed. I will skip this part. So if we talk about outcomes of Holap, in this particular paper from Dr. Mcqs of more than 1,000 Holaps, they found that with time, actually, the flow rates improved over the years, and the AUA symptom scores as well as BPH index decreased. So they have, Holap has excellent outcomes. If in the meta-analysis that have compared it with the TORP, most of the studies have favored Holap, whether it was regarding IPSS scores, Euroflows, or regarding the low PVRs. And they are not just good results, they are consistently good results with IPSS scores decreasing over time, quality of life improving over time, the flow rates improving with time, and the post-vaudesal urines also decreasing with time. Also, the retreatment rate after Holap is very less, as low as 0 to 1.4%. This is one major benefit of Holap when compared to TORP. The complications also in most of the studies favor Holap, be it intraoperative, early postoperative, or late postoperative complications. The only two complications that are more in case of Holap are stress incontinence and bladder neck stenosis. We are always worried about post-Holap incontinence. The incidence was high earlier, but it has decreased markedly with the newer techniques like Unblock Technique, two-lobe technique, or the early apical release, with as low as reported to be as low as 0.7% at 6 months postoperatively with the early apical release technique. We have to be more careful in patients who are diabetic when there's a longer operative time and a very large prostate. In our personal experience of more than 350 Holaps, we have had excellent flow rates and low PVRs in our patients. We have had less than 2% stress incontinence at the end of 1 year. One of our patients required atoms. Less than 2% patients developed stricture urethra. This decreased markedly after we started using the Otis urethratome, and 0.55% of patients developed bladder neck stenosis. This was more common in smaller prostates. So with time, and now there are multiple papers which go on to say that Holap is the new gold standard with good outcomes, lesser morbidity, and lesser chances of reoperation. Thank you.
Thank you, Anuj. That was a very nice presentation, and I entirely agree with you. I think for future, Holap could be the gold standard. It just needs a bit of experience and learning curve from others. I really like your early release of the Apex technique. That's very important in avoiding the stress urinary incontinence. Thank you for joining us. Next, we have open simple prostatectomy. Dr. Ganesh Gopalakrishnan requires no introduction. He is past president of our Urology Society of India and also previously HOD from well-known Christian Medical College, Vellore. His students have become head of the department throughout the world in different parts. And now Dr. Ganesh Gopalakrishnan is going to highlight us on open simple prostatectomy, one of the technique which most of us were not familiar, except especially me. And welcome, Ganesha.
Good morning. Thank you very much, Anand, and to the iTrue group for the invitation. I was a little intrigued as to why you have, I was a little intrigued as to why you have asked me to speak on open prostatectomy, maybe because of my age, or is it because this is really an operation which is being phased out in the world? I do understand that the open prostate is something that many people are shy about, and it's an operation which the anesthetist is terribly scared about, because even before you made the incision, he's already connected the blood bottle. I don't know where they get this idea that this is necessary. But anyway, it has always been known as an operation which is very bloody. And it's very nice to see some of the old AUA videos, which were the unedited version and the other edited version by Ralph Clayman. And these are very interesting videos which are worth watching in the AUA library. So it gives you an idea as to what open prostatectomy. I actually don't like the word simple because there's no operation in the world which is actually simple. Even a circumcision can actually give rise to a problem. So the only disclosure I have to make is that I've got some of these line diagrams which I've taken from Blandy's third edition. I think they're very illustrative, and that's the disclosure that I have to make. What about the history of open prostatectomy? Whenever people talk about history in surgery, the rights are claimed by many because one really doesn't know which side of the Atlantic or which side of the Pacific you are residing from. But in 1885-87, Belfield from Cook County in Chicago has been noted to have done the first open prostatectomy.
Sir, you can share the screen, sir.
Sorry?
You can share the screens, please.
Oh, sorry.
Yes, sir, we can see now.
Sorry, I missed that. But we are more familiar with three names in our generation, and that is Sir Peter Freyer, who actually showed us the suprapubic route, Terence Millen, who showed us the retropubic route, and Hugh Hampton Young from across the Atlantic in the United States, who first did the perineal route. My own experience has been with both the suprapubic as well as the retropubic route, and personally I have not done any through the perineum, and this requires a certain degree of expertise and also specific instrumentation which is necessary as far as this operation is concerned. I just want to dwell a little bit on the anatomy relevant to the procedure. This is purely an extraperitoneal procedure done through the retropubic space. And even if you've gone many times into the retropubic space, one does identify the bladder by the veins which are coursing over its surface. And one can identify the bladder neck by use of a Foley balloon and hitch the Foley balloon, inflated Foley balloon on the bladder neck, and you can feel that. Or sometimes, even if you don't have a Foley balloon, you can actually make out a transverse ridge, which you can actually see sometimes when you do a radical prostatectomy. Distal to the bladder neck is the anterior surface of the prostatic capsule, and there again you have some veins which are coursing over the dorsal vein, etc., coursing over the anterior surface of the prostate. Now this anatomy is fairly consistent. There may be some variations in the number of veins. Sometimes there may be one, sometimes there may be two or three, or sometimes there can be a mesh of veins which you have to take care of during the procedure. What are the indications? There is really nothing to say that this is the indication for an open prostatectomy. But one thing is very clear: the larger the prostate, the better the operation. One tries to do an open prostatectomy for smaller size glands, and I think you land up with bladder neck stenosis and other issues. The larger the gland, the more easy the planes for enucleation, and sometimes you can go to 80, some people say 100, some people say 250 grams. It actually depends between you and what your abilities are. There's no harm in doing a two-stage operation, especially a TURP. I guess today these are all relegated to the back bench, and unless you have a very large prostate with bladder calculi and you think you're going to take a long time, maybe you could do an open prostatectomy for him. If you have a very long urethra, some people feel that the resectoscope cannot reach. Of course, you do have extra long resectoscopes. This is a relative indication. And if you do have a standard resectoscope and a very large prostate, you can still get away with a TURP or a Holap through a perineal urethrostomy. So, really the indications for an open prostatectomy are, if we want to show it to a resident today, and in my own institution right now, we probably do one or maybe two in a year, very large prostates exceeding about 200 grams. And it just makes it easier, and the resident can actually see what a prostate looks like and how an open prostatectomy should be done. The approaches are suprapubic, retropubic, and the perineal. And for the purposes of today's discussion, I'll leave out the perineal approach. What about the intraop preparation? Usually most of these patients are in the supine position. In some of the patients have a very large prostate, and if you've got some short fingers or you've got podgy hands, Lloyd Davis position is quite good actually with these Allen stirrups, because this gives the opportunity for a third assistant to be between the legs of the patient and put a finger into the rectum and elevate the prostate into the wound, and this makes it easier sometimes in very obese patients or patients with a very, very large prostate. Preliminary cystoscopy is necessary because you want to make sure that there's nothing inside the bladder. I know that in today's world, you would have done all the investigations to make sure, but when you're doing a retropubic approach, you hardly look into the bladder. So it's a good idea to actually do a cystoscopy and assess again. After all, we are urologists and we always have the cystoscope handy with us in the operation room. You like to catheterize and keep the catheter in the operative field so that you have it sterile and you can actually take it out or put it back in whenever you want to. A fan style or an infraumbilical vertical incision. And if you're doing the Freyr's procedure, you tend to keep the bladder a bit distended so that you can identify the planes and get to the bladder easily. If you're planning a Millen's procedure, then you like to keep the bladder empty so that you don't have the bladder coming in the way of the prostatic capsule and the symphysis pubis. These are some of the veins that need to be ligated over the prostatic capsule if you're doing a retropubic approach. But if you're doing a Freyr's procedure, you don't need to bother about those veins. You open the bladder vertically, preferably, and then using a diathermy, you go around the prostate on the edge of the bladder neck, as is shown in this diagram. Mind you, the ureteric orifices have to be very carefully preserved, and you've got to make sure that the ureteric orifices are not in any way compromised as a result of the enucleation. Now, one of the things about the Freyr's operation is that although it is an open operation, the entire enucleation is done virtually blind. And you can find the surgeons looking at the right and left and, going around in a trance trying to enucleate a large prostate. But it's one of those operations which, if done well, gives a very clean and elegant looking prostatic fossa. So this is how the enucleation is done. You put your index finger in through the bladder neck and you actually split the anterior commissure, quite like what Tanuj showed with the laser. You just split that commissure, it's quite thin. And then once you split the commissure, you get the planes on either side. And this is where a large prostate helps because the planes are quite nice and you have got that false capsule going right around the prostate. And then when you enucleate the prostate, you have a fossa which is empty like this. And you've got the blood vessels and you will take these hemostatic sutures with Vicryl 3-0 or 2-0, whatever is your convenience. If you've got catgut, you can use catgut. And these are fairly well localized to the 5 and 7 o'clock and anteriorly too. So you could actually ligate these vessels and this will reduce the amount of bleeding into the prostatic fossa. When you want to do a retropubic enucleation, you don't open the bladder at all. You make the incision over the prostatic capsule. I showed you the first figure where the veins were. You just make a transverse incision, usually over the prostatic capsule. Some people make a vertical incision which goes over the bladder neck too. But most of us would probably do a transverse incision over the prostatic capsule. And this would get you right into the prostate. And you'll be seeing the prostate as you see it here. And then you will be able to then again split it and enucleate the prostate. And actually, once you take the prostate out, as you can see the strip of the urethral mucosa, as is clearly shown in this picture. The diathermy needle is quite useful, even the scissors. And if you have a plane, you can actually use a scissors or even a diathermy scissors to aid your dissection. In most situations, the strip that is across between the veru and the bladder neck, you'd like to preserve that strip of urothelium, but in many situations, it doesn't work. It just comes off along with the rest of the prostate, and you're left with the fossa and the verumontanum distally. One of the things, this is how the prostatic factors looks. If you can get that mucosal strip after the enucleation, it's quite nice because it is useful and helps in regeneration and reepithelialization of the prostatic capsule, of the prostatic fossa. If you don't, then you can use this mucosal strip to do what's called retraconization. This is a procedure that's part and parcel of a retropubic prostatectomy or even an open prostatectomy. You want to line that prostatic fossa with a bit of urothelium. Even if you do a Freyr's prostatectomy, you've got the bladder neck, you've got the mucosa at the level of the bladder neck, and that can be stitched onto the prostatic fossa. Or if you've done a retropubic retraconization, this is what is done. And this actually helps in, as I said, in healing. And if you do have a narrow bladder neck, and then you can just do a bladder neck incision at the same time, or a wedge resection of the bladder neck using an Alice forceps and take a wedge out. This happens only if you have done it by mistake in a small prostate. But in large prostates, you don't need to do this, and you probably just have to do the retraconization. After the enucleation, what do? You check again for hemostasis. I think having a bipolar diathermy is very useful here, and you can actually take care of all the bleeders. As soon as you've done the enucleation, one usually puts a pack into the prostatic fossa, and you twiddle your thumbs for 5 minutes by the clock, and just make sure that you're doing nothing at this time. Don't be in a hurry to take that pack off. It does help. The prostatic capsule shrinks, and just like after TURP it shrinks here, and the bleeding gets arrested. At this time, you must ask the anesthetist what the blood pressure is, because sometimes it can get a little low, and you want to make sure that the BP is in the 3-figure mark, so that you're sure that there's no spurter which can give you trouble later on. Invariably, many of these patients have a spinal, or some patients they have a general anesthetic. Then sometimes the blood pressure can shoot up post-operatively, and some of these things start to bleed. Once you pack the fossa and you waited for 5 minutes, you take the pack out, and you make sure that there are no strips of gauze or anything left inside that fossa, because any foreign body left in this large fossa is a sure recipe for vesical calculus or prostatic calculi. So you do a bipolar coagulation of any bleeders in the fossa. I know one of the surgeons who actually, after a prostatectomy, if he's put the patient in lithotomy, that's why he puts the patient in lithotomy, he puts a resectoscope in and fulgurates the bleeders using the resectoscope. I saw this at one of the workshops, and I thought it was a very interesting way to arrest bleeding. Make sure that the 2 ureteric orifices are intact, and check for reflux. Ask the anesthetist to give him a small dose of a diuretic furosemide. See the efflux, satisfy yourself that you've not actually compromised the orifices, and put a large 3-bay catheter inside. A 20 French or a 22 French Foley catheter would be fine. Inflate the balloon and apply mild traction, and continuous bladder irrigation is initiated while actually the prostatic fossa is being closed if you do a retropubic, or if the bladder is being closed if you do a suprapubic. You check for leaks from the bladder wall or from the prostatic capsule. Once you've done the operation, you put a drain. I would say that a suprapubic catheter is optional. I don't put a suprapubic catheter since I have got a 3-way Foley catheter and I've got good hemostasis. This is usually sufficient in the vast majority of patients. So what are the complications? I think a well-done open prostatectomy is a wonderful operation still. It's a feel-good factor when you left the OR that you left really nothing at all, compared to sometimes when you have some bits of adenoma sticking here and there with some of the other techniques. There is really a clean fossa here. The fact that it is being replicated robotically speaks for itself that this is a good operation. The next speaker is going to talk to us about the same operation being done robotically. So, there is a role for this operation. I don't think the complications of open prostatectomy are any different from the minimally invasive procedures. You can have a TURP bleeding, a Holap bleeding, a stricture. All these are there, incontinence, every one of these operations, except the fact that it has a slightly longer hospital stay. But within 4 or 5 days, you can actually send the patients home with a catheter, and they can come back and have their catheters removed as an outpatient. So really, it all depends on how you manage these patients and how you have counseled them before the operation. That makes it a big success. So what about the future? I think this operation does have a role in very large prostates, maybe. I don't know what's going to happen in the next 20 years, whether we will actually see all these minimally invasive techniques being thrown out and have a drug which surely will actually prevent the prostate from growing at the right time. And that's what the future looks like. But before I leave, I need to tell you a story which was doing the rounds when I was in Freeman Hospital in Newcastle way back in 80. And this was a gentleman who was 65 years old who came in with acute retention, and the registrar did a TURP and removed 80 grams of the prostate, and the patient was discharged. 2 weeks later, the patient came back again with urinary retention, and the senior registrar went in and removed another 100 grams transurethral, and the patient was discharged. He came back a month later with retention. This time the consultant did an open prostatectomy and removed 150 grams. So you see, there is a role for an open prostatectomy in today's world. And I'm sure that this operation, although is being slowly relegated to the backbench, is a good operation. It's a good operation if done well and gives excellent results. And that's why probably people call it the platinum standard still. Thank you very much, Anand, and to the iTrue group for this wonderful session and a great learning experience as far as I'm concerned. Thank you very much.
Thank you, sir. We can say that open prostatectomy is just mimicked by endoscopy in the form of Holap and also now taken over by the robotic counterparts. Before you leave, I'll have a question from one of our attendees. Is there any standardized staging or grading of the prostatic occlusion endoscopically? I know last time in the Tuesday class for the DNB students, we were discussing the grading of trabeculations and various gradings. And you mentioned about the urologic encyclopedia book, isn't it?
Yes, I did. The grading is there. It's a book which was written actually by Roger Barnes. Late Roger Barnes was a professor of urology at the Loma Linda University. And he actually wrote this book sitting in my department in the basement, which was at that time in Christian Medical College of Law. And he has dedicated this book actually to all the urologists of India who were struggling at that time to get this specialty of urology recognized. And Roger Barnes wrote this Encyclopedia Urology. And in there, he has given us the gradings of the prostate, both the PR grading as well as the endoscopic grading of the prostate. And he gauges this from grade 1 to grade 4, depending on whether the lateral lobes are meeting together, whether the medial lobe is sitting there. And this is done by looking from the verumontanum into the bladder and whether you can see the prostate, whether you can see the bladder neck and the posterior wall of the bladder at all. So these are the gradings, and I would recommend you to look at that grading in Encyclopedia Urology, grades 1 to 4. It's quite well written there. So this is the endoscopic grading from Roger Barnes.
Yeah, it's a book very difficult to get. I think the physical book copy is present only like 4 or 5 copies in India. But,
absolutely, yes. There are very few copies left. I don't know whether somebody will have it in Loma Linda, because I'm sure it must be somewhere in some of the archives, at least the AUA library or even in Loma Linda University Medical School.
No, after your Tuesday
we
class,
had one in our department. We still have it in our department.
Yeah. No, after your Tuesday class, I located a book in the Amazon website. It is sold for $50. And
really?
So it comes on and off. People are selling their old books like paperbacks, and I've ordered it on Tuesday evening. Right.
Very good.
Thank you very much.
Thank you for the information. We'll pass it on to everybody.
Yeah. Our next speaker is Mr. Hassan Kwasi. He's from St. George's. He's got the largest series in the robotic assisted simple prostatectomy. It is just mimicking the open prostate, but with a much better view and much better hemostasis. Now, he's going to convince us how robot can be used in this. Welcome, Hassan.
Thank you very much. And thank you very much to Professor Gopalakrishnan. You've made my life a lot easier. And believe it or not, in the course of your presentation, I've actually deleted 2 of my slides because we've got a very nice insight. So following on from the last presentation, we know that simple prostatectomy, again, in inverted commas, simple for the reasons stated, is a gold standard time-established procedure that works. And in the world of minimally invasive surgery, we know that laparoscopic simple prostatectomy has been around for about 20 years. And of course, that was followed by robotic simple prostatectomy that was first described in 2008. Now, why our institution at St. George's? So over 50% of our population that we look after are Afro-Caribbean men, and the prostate volumes tend to be significantly larger in this cohort. We know that from our robotic radical prostatectomy series. We had also had a bit of a problem, which is the dying scale of open surgery, and to be able to do something as well as Professor Gopalakrishnan, which not many of us can do. We're experienced in robotic surgery. We don't have a Holap service, or we didn't have one established. And who wants to look after a patient with a 300-gram prostate and an indwelling urethral catheter? It's a difficult one. Certainly, when I did my fellowship, we had published extraperitoneal approach regarding robotic simple prostatectomy. So we started, and we are doing now about 20 to 25 cases per year. So a good old little hand-drawn video. How is the procedure done? So again, patient is positioned in Trendelenburg position, just like a robotic radical prostatectomy. Those are the legs, that's us looking down. We have a standard 6-port approach going in, and I tend to do the procedure transperitoneally. That is urinary bladder, again, prostate gland. You've got the endopelvic fascia and the pure prostatic ligaments that we do not go near, and the urethra again is untouched. I have a combination which is almost like a hybrid technique between Frere's and a Millen's. So it starts off with a vertical hemi-incision in the anterior surface, starting at the junction of the prostate and the bladder. I use straight silk from the outside on a needle and clip that, and that provides us with a nice open window through which we can access this. The ureteric orifices are visualized, clearly spared, and the first incision, just as we'd mentioned, essentially starts off at the edge of the prostate, just under the urothelium, until you get to that nice plane between the central and the peripheral zone. I normally use a big stay suture, something like a number 1 V-lock to elevate the prostate, and that can actually be very useful. If you have a robotic tenaculum, it's very good, but of course, that's an expensive instrument, so you're adding a few hundred to your cost. And again, you just develop that plane laterally until you go down. For over 200-gram prostates, I fracture the anterior commissure because access to the apex can be a bit difficult. We don't need a DVC stitch in the robotic technique because of the pneumoperitoneum, you get a very nice hemostasis. So again, a bit like the open technique, what you have at the end is peripheral zone, nice cavity, UOs, and raw edge of the urothelium. And essentially, we retrocognize every single patient, and I start just at the sphincter and take the urothelium all the way down. This arrests bleeding. And the other one advantage is that patients tend to not get storage urinary symptoms post-procedure, and their functional recovery tends to be quicker because there's a nice epithelialized or mucosal surface there. We leave a catheter in, essentially close the bladder, and that's pretty much it. So pretty straightforward. So again, this is our the NET procedure. We normally have a talk clinic twice a week, so we talk the patient between 3 and 7 days, depending on how the procedure goes. We've had one patient with prolonged catheterization, and that's because he had a dense urethral stricture that also had to be dealt with. So again, sorry, this is going to be a very sort of condensed video, but essentially you can see that's me looking down into the cavity. The adenoma I have already lifted up. It's in my over the left side, and again, it's just a case of shelling things out quite nicely. And as you go along, again, you keep developing that plane. It's a combination of diathermy, blunt and sharp dissection, and you end up with a nice plane that goes all the way around. Now, big advantage of this robotic simple prostatectomy, of course, we'll talk about prostate size, is that this patient, for example, had a diverticulum. We've also got patients with very large bladder calculi. So rather than having multiple procedures to deal with bladder diverticuli, you can do it at the same time. And as a consequence, we've actually got the UK's largest series of robotic diverticulectomies as well. So it's a one-off procedure, which you can actually deal with all the things at the same time. So again, this patient, you can see that's a large diverticulum. The bladder is there. That's the cavity that the diverticulum had occupied. And you shell out the diverticulum prior to doing the simple prostatectomy. And it's fairly straightforward. In the end, you have a situation where, again, because of your very nice vision, you can see diverticulum. That's the opening to the bladder, incision, and closure. So once again, it can be combined with other procedures. I've got fairly large hands. One adenoma, this patient had a 400-gram prostate. Again, another patient, very large prostate gland, that's a nurse holding it in her hands, and that was the diverticulum that was removed at the same time. Another case, very large bladder calculus and a 160-gram adenoma shelled out. So it's a useful procedure, and it does provide access to a plethora of other things. Now, we have looked at our series where we've looked at massive versus supermassive prostatectomy patients. So we would not offer the technique to anyone with a less than 100-gram prostate. That can be dealt with quite conveniently by a TURP, bipolar enucleation, Holap, etc. Our default setting is prostates well over 150 grams, and we've compared our outcomes for the two. So we have now done 65 patients, but these are the results for the first continuous 52. The average age of the patient is 72.1 years. The range is between 55 and 82. They tend to have a large BMI, and in our series, the prostate size is up to 465 grams. The mean is 182 across the ranges. Now, you can see that 71% of our population were catheterized. So essentially, this is a cohort of men with large prostates, indwelling catheters, and often things like visible hematuria, quite difficult to manage in general. Well, these are the outcomes. So intraoperative blood loss absolutely is more than robotic radical prostatectomy and is higher compared to the other operations that we've talked about. But again, this is a cohort of patients with very large prostates. We have transfused a total of 3 patients, but all of these 3 patients had a starting hemoglobin of less than 10. And it's because they'd had recurrent admissions with visible hematuria, had indwelling catheters, etc. Nobody with a hemoglobin of over 100 has been transfused. The console time, again, tends to be a little longer than robotic radical prostatectomy, but again, not hugely so. We had 3 patients who had 1 pad usage which was temporary, and all of these resolved at 3 months after follow-up. So we've had 0 long-term incontinence, and 2 patients who had temporary urgency incontinence that needed treatment with an anticholinergic, and 1 with combination treatment. By the time he attended for urodynamics with a view to intravesical Botox, it had settled down. In terms of our complications, 3 patients required antibiotics afterwards for an infection. 1 developed epidermolysis. And of these 4, 3 had an indwelling catheter before the procedure, so again, higher risk. 1 patient, unfortunately, had an extraction side wound dehiscence that had to be reclosed. Talking about simple prostatectomy robotically versus open, well, we know that there is a shorter hospital stay, but longer operative time. The blood loss tends to be less compared to the open technique because a lot of the veins can be tamponaded, and the results are fairly similar. So essentially, we have taken a time-tested technique for very large, complicated patients, and we've translated that, hopefully successfully, robotically. Paolo Omari is one of the consultants in our unit currently, and they've compared Holap versus robotic simple prostatectomy. In this series, the average size was a bit smaller than ours, but essentially the outcomes are quite similar and the complication rates are quite similar as well. One of the advantages, of course, is that if you are an experienced robotic surgeon, and that was one of the reasons why I undertook this, is your conversion rate is pretty much 0 because there is no advantage in opening up. And of course, Holap being a less invasive procedure, the mean operative time can potentially be a little shorter, and at the same time, transfusion rates and other things are broadly similar when you talk about prostates of less than 100, but in the larger cohort, of course, we have a more bloody operation when you do a robotic simple prostatectomy. So this is not a very large patient number, but again, the largest series to date. And certainly in our experience, robotic simple prostatectomy, it's safe with low incontinence rate and complications. It's safe in supermassive prostates with benign hyperplasia. And it's especially useful when patients have divertically bladder calculi. You can deal with everything in the one sitting. The learning curve, I believe, is probably accelerated compared to Holap. So in somebody who's an experienced robotic surgeon, probably between your 5th and your 10th case, you are very comfortable staying in the correct plane. And of course, we need comparative data for this subset of patients with BPH. Thank you.
Thank you, Hasan. That was a very nice presentation, and certainly Holap replicates what we are doing in the open simple prostatectomy, but in a much more easily visually appealing way, which obviously gives us better hemostasis and better, quicker post-op recovery. Now we are well over the time, but we have almost 325 participants online eagerly waiting to have some more information. First, let me share the MCQs, and so that will give us an idea about how the participants have performed. So the first question is the Abraham-Griffiths number. What is the bladder outlet obstruction index? It's PDET at Qmax minus 2 Qmax. The second question is the most difficult for most of you, I believe, because of non-availability of Eurolift in various parts of the world. And the question is, what is the urethral tab of Eurolift made of? But those who have very attentively listened to Petro's talk, he did mention this. The urethral tab is made up of stainless steel, while the capsular tab is nitinol and the suture is a PET suture. It's very common to select titanium, which is one of the commonest implant used in orthopedics. A PSA level of 1.4 or higher indicates the increased risk of BP progression. This is one of the commonest correct answer. This question is taken from the Scientific Basis of Urology. One of the very old book tells us about the basics, and following are the theories to explain the bladder neck opening, except all the theories were correct except the fourth one. The fourth one is simple hydrokinetic observation, just the change in the name. And this is to say what is normal. A normal person voids on an average about 300 ml completely in 40 seconds in 6 times a day. Unfortunately, as I said, none of the participants were able to answer all the 5 questions correctly. That's because of the question with Eurolift in them. 3 of them answered all the 4 questions correctly. They are Neri Parajara from Paraguay, Mr. M. Anas Abu, and Firas Kana from Syria. Congratulations to them. They scored 4 questions out of 5. All 3 made the mistake only in the Eurolift question. That shows the acceptance and availability of the minimally invasive technologies all over the world. I'm just going to ask few questions for the panel before jumping into the case scenarios. I don't want to really spend a lot of time in the case scenarios because we have few questions to ask from the participants. A question for Tanuj. What is the preferred laser settings for Holap? Is there any advantage when compared to bipolar enucleation?
So most of the people actually prefer to operate at highest settings, that is 2 joules and 50 hertz. I personally prefer to operate at 1.5 joules and 50 hertz, and near the sphincter I prefer 1.2 joules and 50 hertz. So about 60 watts near the sphincter and about 75 inside the fossa is my preference, but I've seen that most of the people prefer to use higher wattage. Definitely over bipolar, the bleeding is lesser, enucleation is better, because most of the bipolar enucleations that I've seen are more of mechanical enucleations, and the bipolar is just used to coagulate. Whereas in laser, we use the laser energy to enucleate as well as coagulate. And definitely the stricture rates of bipolar that are higher than Holap.
Thank you, Tanuj. Next question for Gayampalo Sena. The question is, what about the post-op incontinence and recovery post-resume?
So recovery is actually pretty fast. Patients are discharged 4 to 6 hours later. They go home with a catheter, and as we discussed in the presentation, the catheter is left in place for from 0 to 7 days, according to the case and the surgeon's preference. The side effects, dysuria and cystitis-like symptoms are the most likely adverse events patients can refer, but typically they can go back to work the next day with the catheter in case you place the catheter. So the recovery is pretty fast.
Okay, good. The next question is I want to direct to Hassan Kwasi. If there is a patient who is waiting for radical prostatectomy, but unfortunately has a 200 cc prostate and he needs a bladder outlet obstruction surgery before going ahead, what is your choice? I know you will, you have robot and you may even tend towards radical prostatectomy, which will tick both the boxes of de-obstructing the bladder and also the cancer treatment. But if he is heading towards radiation treatment, do you have any options for him?
So the answer is yes. We have had, interestingly, a couple of cases where men were heading for radiotherapy. We'd done prostate biopsies with a very elevated PSA, 27.4. And if you do a robotic simple prostatectomy, straightforward, the functional outcomes we've been able to demonstrate are very good. And in fact, the PSA dropped so significantly that it wasn't needed at all. So of course, this wasn't high-grade disease, it was Gleason 7 cancer. So number one, pre-radiotherapy, it would be no different, in my opinion, to anything else, like Holap or any of the other modalities. Yeah, you're absolutely right. Certainly, once you've got experience, size is not a consideration. In experienced hands for robotic radical prostatectomy, one can take on prostates of any size. The early continence, because of bladder neck reconstruction, tends to be a little more difficult, and nerve sparing can be a little more difficult, but it's not a contraindication. So in essence, you can do RRPs of any size. And number two, yes, it's a safe operation to do for disobstruction pre-radiotherapy.
Can I just, excuse me, can I comment on this, please? I actually asked this question. The question was, if a gentleman is not suitable for a radical prostatectomy but does have high-risk prostate cancer and has got significant voiding lower urinary tract symptoms with a relatively large prostate, and you want to optimize his lower urinary tract symptoms prior to radiotherapy, what are the options? And the reason I asked this is that this is a big prostate, and because it's an aggressive prostate cancer, Holap is often considered an unsuitable option because you can't find the layers. And I'm not sure if any of the other minimally invasive operations are necessarily suitable within this scenario. And this is one place where I think the conventional TURP may still be the only option you have.
Pavan, absolutely correct. Endoscopically, great. But that cohort of patients with aggressive prostate cancer and say a 200, 300 gram prostate, no one wants to look after. And I think as experienced robotic surgeons, people like you and I, we do have a role here. And this is where, even if you are not able to find a layer, and you are, of course, you cut into cancer, we've got amazing access to high pressure, we've got good access to bipolar diathermy, and actually, it works well. So I don't have a large experience, but we've done about 6 patients who've had prostate cancer, and the outcomes were good. So yeah, I think for people like you and I, that would be probably the way forward.
Good. The next question for the full panel, anybody can take up the question. If there is a relatively fit, say 76-year-old gentleman presents with chronic urinary retention, he attends A&E with inability to pass urine, bladder distended but not painful, catheterized, 1.2 liters of urine drain. So in this situation, if he has say 80 cc prostate with hypocontractile bladder, let's assume he had a urodynamically proven hypocontractile bladder, what is the choice of surgery?
Anand, if you're asking me?
Yes, sir. Anyone can.
I would do a TURP for him.
But we need to warn him regarding the post-op need for self-catheterization.
Yes. But we do know that men who have got an endoscopically large prostate, and even though they do have a hypocontractile bladder, their outcomes are better than somebody who has a smaller prostate and a hypocontractile bladder. And there's always this 50-50 chance that, and most of these guys actually void. And if they do have a residue which is, in the range of about 50-100 cc without incontinence or recurrent UTI, forget it, he's all right. He's happy, he's passing urine. He came with 1.5, he goes home with 100 cc in his bladder, it's okay. So I would go for a TURP.
I agree.
Yeah. But having said that, there are some good evidences to prove that whole knee enucleation also has a place, and it has a better deobstruction, and sometimes patients' need for intermittent self-catheterization is a little bit lesser in frequency compared to relatively not very deobstructing surgery. Depends upon how good deobstructing we do. One question for Petros. A 45-year-old gentleman presents with history of voiding LUTS symptoms, and you do a flexible cystoscopy which shows just high bladder neck. There is not occlusive lateral prostate lobes. What is your choice, Petros?
Well, first of all, just to make a brief comment on the previous question, I would go for green light. Definitely something more destructive, if I may call, in terms of the prostatic tissue, rather than the other modalities. A big topic. Basically, you need to facilitate him if he resorts to intermittent self-catheterizations, open up the bladder neck. So that would be my choice. Now, coming to that question, we are aware of Peter Chin's work in Australia, where he demonstrated some modified procedures, combined BNIs and Eurolifts. So if the guy is extremely keen to preserve sexual function, probably antegrade ejaculation, I would go for a Eurolift. Now, we have some cutoffs. I mean, if the bladder neck is above a specific height, as we view it in the cystoscopy, I wouldn't say that it can be very promising. But again, it depends on the patient's expectations. Dealing with him and explaining to them fully what to expect is of the essence. So if he agrees, we can try and do a combination of Eurolift and half of a BNI at 6 o'clock. He needs to be warned still, but there could be, sorry, we said there was no BPE, just a bladder neck.
Yes, thank you.
Was that the question, just BNI? Yeah, I would just go for a partial or a limited BNI. Now, we have some experience in our hospital, not many cases, I have to say, with a partial BNI, and it went well without compromising ejaculation. If there is a small element of BPE, then you can throw a couple of implants on iTrue. That will be the answer, the best suited option, in my view.
Thank you, Petros.
Can I come in, Ananda?
Yes, please.
I think it's important that we have to. There's a simple principle that anatomy and physiology don't always go hand in hand, and therefore you really need to assess these patients urodynamically. You don't want to do an unnecessary operation with the hope that 50% will improve. So I think, if you only have a bladder neck which is high on cystoscopy, you really need urodynamics, video urodynamics even, to look at the bladder neck and see how it's opening during voiding and measuring the pressures. So I think, I don't think we should be operating on men just on cystoscopic examination, because we know physiology and anatomy are not always hand in hand. Yes, if the prostate was 100 grams, it's occlusive, then yes, you have a good chance. But if the prostate is small, then we need to assess the bladder neck.
Yes, I agree. Even the NICE guidelines for LUTS states extremes of age, those who are in 4th decade or nearing the 8th decade, it's better to quantify the bladder function and the overall bladder neck and other functions before we go for any bladder outlet obstruction. Ashim, when you're there, there is a question. We have, in evaluating of men with BPH, we come across erectile dysfunction as one of the findings. Sometimes the patients will overtly express them. Sometimes we need to really ask some pertaining questions to get it from them. We have IAEF 5 questionnaire, which is quite good for the clinical practice, and there is IAEF 15 questionnaire. Is there any role for IAEF 15 questionnaire in day-to-day practice other than the research or audit purposes?
I think sometimes you have to take a balance between practicality and research, really, and pragmatism. So IAEF probably does number five, does the trick for clinical practice. And I think the IAEF 15, you have too many questions. If you have the ICIQ and LUTS with 13 or 15 questions and the IIEF with 15, and then you have other questionnaires, then the patients can have, and a bladder diary, you may get a lot of fatigue with questionnaire filling out, and therefore I stick with pragmatic. The ICIQ and LUTS is good. The IIEF is good. You combine them and you can get good data from that.
Thank you.
So I would stick with the IIEF.
Okay. So there are two more questions. Yeah. Go ahead, Hassan.
I absolutely agree with I would say that as long as we are checking, because we have a single stop, what's called rapid clinic, where men come in with a high PSA and have an MRI scan and get seen at the same day. And we started asking every single man, they all got an IPSS and an IEF sexual function questionnaire, and 40% had ED. They were embarrassed to talk about it, and that was one of the reasons that they'd gone to see their GP. So as urologists, we absolutely need to be aware of that very important aspect, which is also important in counseling men in terms of the treatments that we have to offer. And the second thing I would just say is all the treatments that we've talked about clearly work and are great. And I think for a lot of these patients, I could offer a robotic simple prostatectomy, but someone could offer Holap. So it really depends on your experience and expertise rather than the one treatment being the fix-all. Thank you.
Yeah. Thank you, Hassan. I have three more.
Can I just,
yeah.
Just to finish? I apologize for the misunderstanding. I thought it was approved BOO, and we were at the previous question, and we're just focusing on the urodynamics is of the essence. Yes.
Yes, Petros. Yeah. So we have three more quick questions before we close this session. The questions were for Maya Harris, Sachin, and Ganesh Gopalakrishnan, sir. So question for Maya. You have this green light, is it 180 watts laser? And if so, is it really advantageous compared to the older generation 120, Maya?
Oh, yes. If you have a larger prostate, what you do, you kind of work very delicately around bladder neck, and then you work delicately around the veru, and you end up with a kind of a BPH just prolapsing in there, and then you can whack up the power, and the prostate just melts. It disappears, on a high power setting. You cannot do high power setting, around the delicate areas. But when you're dealing just with the bulk, it's very much to the advantage. And the procedure goes quicker, and you are done, the patient out of the theater.
Thank you, Maya.
That's the advantage.
Yeah, that's all we want.
Yes, I like, high power setting, but you've got to be experienced because it could just melt through the tissue in a nick of time.
Good. So as long as our weapon is very powerful, we should be very careful in using it, as we say. Next question for Sachin. Sachin, you're called by your close urology colleagues that there is a 85-year-old gentleman bleeding from the prostate, 150 cc prostate, but not fit for any GA intervention, even a bladder clot evacuation. Do you think those patients in an acute setting bleeding will be suitable for prostatic artery embolization, especially if the vessels are okay?
Yes, absolutely. I think that's a good indication. And, for those type of patients, you don't need to be as selective, and you can use different types of embolic agents because you're not looking to cause, tissue necrosis. You're just looking to block the blood vessels, essentially. So you can use temporary embolic agents like gel foam. I think that's a good indication, and that's a good way for radiologists to start doing some prostate artery embolization. If they haven't got the other indications, they could start doing it for bleeding. I think that's a good way in.
Thank you, Sachin. And the last question is to the master of the masters, Dr. Ganesh Gopalakrishnan, sir. The question is, between the Freyers and Millin's open prostatectomy, which one is having less learning curve, or which one is more difficult to learn? Which is your preference?
Well, I think any day the retropubic approach is much better. because you're sitting directly on the prostate. You don't have to mess about with the bladder at all. And especially we're talking about large prostates. So it comes out into the wound literally, and you're able to do a good job. I wouldn't say that there's too much of difference in the learning curve. There's always a fear that because the prostatic capsule has got the veins, that there will be more bleeding, but actually you can underrun these vessels before you actually make that transverse incision over the prostate capsule. Well, there's no doubt about the fact that when you're learning to do an open prostatectomy, the operation that is done is a FREAS, that is a transversical prostatectomy. That's what is taught to you so that you get that plane of cleavage. But you can do it even the same way with retropubic. It's just that for some reason, there appears to be this difference in terms of difficulty index, but I don't see anything different.
Thank you.
I think it's about the same. Thank you.
Thank you. Thank you, everyone. Thank you very much for the panelists for sacrificing your 2.5 hours and also the preparation time on Saturday. Not a bad climate. We have pretty okay brightness in the daytime. And many thanks for the participants. We have almost more than 325 participants all over the world. And it's so glad to see that people are logging in from very remote locations. And I think, but for these kind of webinars, it's very difficult for them to understand what's happening in the real world. And whatever we read in the books or publications won't be equivalent to the word of mouth from the real practicing persons. We have tried our best to cover the complete armamentarium for BPH, but I'm very mindful that we have left aquablation and also the so-called old gold standard bipolar TURP. But we thought of dividing this whole seminar or webinar into like a part 1 and part 2, but we have made it into one. Thank you very much again for every panelist for your time, and hopefully we will see you again almost a similar webinar maybe in 1 year time, and by the time we will have at least 2-3 extra energy synopsis to discuss. Bye for now.
Thank you very much.